content, we discussed a bit of nursing documentation, and we talked about I&O and dynamic documentation, and we reviewed specifically the CTCAE toxicity grading and how that can flow directly onto oncology flow sheets. There was a question regarding professional practice and if there was a requirement to document none in iView on all of the CTCAE toxicity grading assessment components. So I did reach out to professional practice, and the coastal professional practice response was documentation needs to reflect nurses' assessments and clinical decision making, and VCH does not endorse a charting by exception. I did explain to them that the CTCAE toxicity grading does have over 100 different boxes, and that is quite tasky to ask nursing to select none in every single one. They are going to reach out to RHS and VA professional practice for their input, and I'll follow up. I can reach out to you guys over email to let you know their response, because ideally it's not ideal to have to select none on everything. I think we can all agree on that. So I'll let you know what Richmond says. Any questions for that?
Thank you for looking into that.
Yeah, no problem. Okay, so we'll talk about inpatient to oncology clinic for treatment. So we'll first discuss LGH and then we'll discuss the Squamish and Seashell. So all oncology orders will need to be activated within the inpatient encounter by an oncology provision clinician, so an oncology nurse. So there's a requirement for the oncology clinic nurse to liaise with the inpatient nursing to administer the pre and post treatment orders, whether that's over the phone with the oncology clerk reaching out to the inpatient team or vice versa. So the steps for this, the oncology clinic will activate the day of treatment order. The inpatient nurse will then be directed to administer these pre-treatment medications. Then the patient will come to the oncology clinic, and the oncology or chemotherapy medications would be administered in the oncology clinic and signed off by the oncology nurse. And then, oh, Karen?
So this is for like our oncology patients being admitted or that are currently admitted.
Yeah,
So
inpatient oncology patients.
okay, so if like they currently, like if we have to do anything for inpatients, we have to go to their inpatient encounter. This order set will probably be on their chemo encounter. So how does that work?
That was my question too. It's like usually we have to go into the separate encounter to see the order and they won't see it.
Mm-hmm. So these orders, oh, Haley, go ahead.
Oh no, it's okay. I want you to have it. Go for it.
So these treatments have to stay within the inpatient encounter, because the patient's current encounter is inpatient. I don't know. Haley could probably do a better job.
So will the oncologists have to order their treatment on their inpatient encounter instead of on their chemotherapy encounter?
Not necessarily. Yes. She's not. It's basically it's kind of a choice. We find that usually if the oncologist goes, at least what we've learned with these are future orders. So when we place them, they float until they're activated somewhere. So it's probably the difference between what you guys are currently doing and what you will be doing. The doctor can place them on the clinic encounter, but if it's an inpatient, it does need to be documented against the inpatient encounter, is what we recommend. So the way that works is that the doctor places it, as long as they place it. Our pharmacy is better if they place it in the inpatient encounter, and they know where the patient's going because then they know the patient's an inpatient. But then the clerk schedules the appointment that's associated with this treatment day to the inpatient encounter, and then patient gets checked in when they come to clinic on the inpatient encounter. You perform the you guys probably have your own workflow that you are currently doing now, but it's not with orders, like future orders.
Well, it is for blood products and things, so their appointments are tied to the blood product. But if a patient was an inpatient, we will go into their encounter and add, like, say I gave somebody dexamethasone here, I want them to know upstairs when I give the patient back that I've done that. So I will go into their encounter, order the drug, sign the drug in their MAR so they can see it. Or if I want them to give it as a pre-med.
Definitely, so they definitely need the order. Technically, so there's a few things that I'm hearing with that one. I mean, if we're transparent, practice doesn't want nursing placing orders, like out of, you know,
We've
just
already
even.
got the order. It was just so that they can see it. Like, we've already, because we're on paper, we already have the order.
Yes,
And
exactly.
I've already
So
given
now
it.
the order, yeah, and now
I
the
just
order's
want them to
electronic.
see it, but ours is on paper, so I want them to see it in the computer. So I want them to see it. Anyway, we often here will go between encounters, but I see
Yeah.
no reason why an inpatient nurse would even know that you can do that, because they would never have to.
Yeah, so in our future state, at least was what we're using at Richmond and at VGH and at Coffet, is we just use the inpatient encounter, and technically that's what the patient is inpatient, and the orders flow on the inpatient encounter.
And then would we sign, like, say, the doxorubicin on the inpatient encounter also when they're in our outpatient clinic?
Yeah, it shows the outpatient clinic location, but that it's an inpatient that came to your space. And I know it's different.
Okay.
The difference being that, like, if we try to do this in future state with these orders, is that it's just hard to do the activation between what you need to give as pre and post, which might be the inpatient space, and what needs to be given in the clinic space. So that's why we recommend for you guys, with the way that your location's built, this is what you can do. But you know what we can do is dive into, because you LGH have a space that can host inpatients in your clinic, like you have the ability to transfer, not a space, like a location in Cerner. You do have a chemo hold that will take it. So what we can do is show the other workflow, which is what Seashelt and Squamish would need to follow. And it's what LGH you can continue to do, but you'll find that there's just a little more encounter management. So let's show that one. And then, does that sound okay, Karen and Lee? Yeah? Okay, awesome.
Okay, so for Squamish and Seashelt, so order activation management required by the oncology clinic between inpatient and recurring encounters. So similar, the oncology nurse will have to liaise with the inpatient team to administer the pre and post-treatment orders. So this one, the oncology clinic will activate individual pre-medication orders on the inpatient encounter. Then the inpatient nurse is directed to administer these pre-medications. Then when they come to the oncology clinic will activate the day of treatment and administer the treatment on the recurring encounter. Any post-treatment orders to be ordered on the inpatient encounter for administration by the inpatient nursing.
So I will call it, because that probably mirrors LGH, what you guys are doing right now, more so, but I will call out that the orders say for post-treatment, like if it said like post-bolus or in 2 hours, there's a Lyrice that I know there's a 2 hour, like 2 and 4 hour melphalan kind of dosing or whatever, or leucovorin dosing. There's, things that need to be ordered on the inpatient counter. System won't stop you guys placing those orders. They would have to be discontinued on the recurring encounter, and they would have to be placed on the inpatient encounter. And technically that needs to be done. If we're saying what policy says, that has to be done by a doctor to place the orders. Even though you had them on this order, it's the order in system has to come from a physician. And so that's the harder sell on that one. Does that make sense?
I'm not following it all completely, to be honest.
No problem.
And
Yeah.
then also around like this order that needs to be activated, like our nurses might not even know till 1:30 their patient's due. Oh, they're an inpatient. So then all the pre-meds have been missed. Like, who's looking ahead to see which of our patients are inpatients or not? Like,
we usually so what we've heard at other sites is that there's usually a pre-treatment, like pre-chemo check, even in whether it's the day before or in the morning, like when the nurse is assigned to patients. And that's when they would note that.
Not sure that will always get caught.
Yeah. That's a tough one.
Mhm.
Hope, you got your hands up.
So with these the dexamethasone, all the pre-medicines, and the oncology nurse will call the inpatient nurse and ask her to give these. So will the inpatient nurse, if this is on like a pre-reoccurring encounter, outpatient encounter, will they have access to like scan and like administer these in the inpatient encounter?
They will be, if they are activated in the inpatient encounter by the oncology nurse, then they will appear in the inpatient encounter.
Oh, okay. So it'll always be on the inpatient encounter. Then there will be no pre-reoccurring encounter or inpatients for the clerks to be doing the scheduling for oncology.
For scheduling, I'll let Haley answer that one.
Yeah, so this is the one for Seashell and Squamish. I know it's different. We don't have the ability to go back and build the clinics out. So how your clinics are built, you don't have a space to even bring an inpatient encounter in, because that's just not a normal workflow for you guys, as this is fairly low volume is what we understand. So for this, it's kind of tough. I want to take it back to the paper, because I know that's how I try to understand it. So if say that you have an inpatient MAR and you have your clinic MAR, what we're recommending, or what would need to be done, is that these, say any pre-medication order would need to be transcribed on the inpatient MAR, so that the inpatient nurses will give that. So in system, what that looks like is a right-click activate of Dex, Ondans, and Aprepitant, say in this, on the inpatient MAR, so that the nurses can then go and administer a scan and they can do the administration. But someone needs to put it there and let them know that they need to administer it. It's similar to maybe current state. When they come down to your clinic, they will have been scheduled to your clinic encounter. So it's like the inpatient bed will just go on hold, and it'll have the patient in your space, in your outpatient space, and you'll activate the whole day of treatment and then perform the treatment, and then the patient would go back to the inpatient space. If they needed any post-treatment orders, especially like SC nausea is a common one, that would need to be activated on the inpatient encounter, so that they have it on their MAR.
So just to be clear, while the patient is in the outpatient clinic, we have our own encounter that we're working with.
Yeah, and it's just a matter of being cognizant that if you want the inpatient nurses to do anything like pre or post treatment, it does need to be activated or ordered on their encounter.
On the inpatient encounter.
Yep. Back and forth. Yep. Tash?
Hi, thanks, guys. And just to go, because I see at the very bottom, it says if we are going in on an inpatient encounter, which again is rare in Squamish because we rarely share these patients. If they're an inpatient, usually their chemo is held because they've got some comorbidities and chemo is not happening. But is it the nurse or the provider that goes in and activates these? Is it supposed to be provider? It is the nurse that activates the pre-medications?
Yeah.
Okay. And then okay, and then same with post-treatment orders?
Would be the nurse to activate, yeah.
Nurses activate all of them. Okay. Okay.
That being said, others have the power. That's what's been put in place at other sites. I'm learning that every site's different. Obviously, every site's different for who they have and where it naturally fits in for someone's position or role to do this. It's been my experience we have at VGH, we house the BC cancer inpatients, because they only do planned treatment. They don't do anyone that's sick and needs treatment. So VCH takes the VGH takes the BC cancer patients. It's a hard, it's easier to have nursing do it. This sounds bad, but the nurse is the one that's looking at the orders more like every day, and nursing from oncology clinic can speak with nursing that's always fairly available on the inpatient space, and it's easier to liaise between nursing. When we've had providers ask them to do the activation, it gets missed. But that's a different setup too. Karen, I see you smile. It's because the BC cancer providers don't stay in our units, right? They walk through the tunnel, they go and order the thing, and then they leave. And so that's why previously at other sites it's been nursing. What works for you guys might not be the same. So those two options being like for you, Hope, and for Tash, you had to drop off. That's okay. This is the only way that we can work it out with the way that your clinics are built. So this is something that we'll teach, and we will help in those first weeks after go live of how to manage it to get used to it. For you, Karen and Lee, it's a matter of having the two choices. I think they each have their pros and cons, but maybe the second choice is the devil, you guys know, in a sense of like the multiple encounter management. So, well, I think it's ultimately your choice. It's just a matter of which way it would work best for you guys.
Yeah.
Did you want to take it away?
Yeah. Can you send me these two slides and just,
Yeah.
I think, so really with the first one, everything is going to be done on the inpatient encounter. And there's no going back through charts. Like it's just one encounter.
And there's no having to like order the post treatment. Like someone has to place the orders for the, like manage back and forth, right? Like, oops, I accidentally activated that on the recurring. I don't have to know. It all needs to flow. It flows on the inpatient.
Okay. Yeah. And that all still carries over for documentation kind of thing. That's yes, the docs, it was given, those sorts of things. Obviously.
Absolutely.
Yeah.
Yeah. Okay. All goes to oncology flow
Might
sheet.
just be a change of our practice. Might be.
Yeah. Yeah, that's great. That's a good point. So yeah, it's definitely up to you guys, and whatever we train is what we train. If the two options are feasible, it's just a matter of what would work for you guys. I think that's
so
all.
For the first option, we're not transcribing any orders. We're just clicking, calling the ward and saying, can you give these pre-meds?
Yeah, you are gonna, you'd activate you would activate some of the orders, the pre-medication orders for them, but just saying, you're not searching on DINs and you're not searching DEX and placing it like an app. It's all within the treatment plan. Yeah. Yeah, that's great. Okay, thanks. Sorry, I took over just because Alex, that one's new for Alex, and this is one that we've seen at a few sites, so I thought I'd chat on it. Thanks, Alex, for giving me.
Thank you, Haley. Okay. So now we're going to discuss treatment within inpatient acute spaces. So again, this is LGH. So just a high level workflow of what that would look like. So patients receiving treatment in the inpatient space. So the provider would determine that the patient is to have chemotherapy administered on the inpatient unit. They will enter or modify the chemotherapy orders on the inpatient encounter. They will add the phase administer oncology treatment on the inpatient unit and an off-service chemotherapy RN order. So this will trigger to the pharmacist that they see the notification of the off-service chemotherapy, and they see the order of administer oncology treatment on inpatient unit. They will then verify chemo medications and complete prep. So then the oncology nurse will be notified that the patient is requiring off-service chemotherapy, and this would be a phone call from the provider to let the nurse know. On the day of treatment, the nurse will then communicate with the inpatient nurse to determine the chemotherapy administration time, and they can also activate any medications required for that inpatient nurse to give. And then they will also communicate with pharmacy to determine when the medications are ready. And all of this will occur on the inpatient encounter and by the oncology provision clinician. Any questions with that one?
But that patient will still be brought to our clinic for administration or not?
No, they would stay on the inpatient unit.
So only if that's applicable for your site. So some like VGH needs this availability for like ICU patients because we don't want but they still give treatment on their, yeah. Does
We
that
do
sound,
that.
is it not applicable for your site?
We do it once or twice a year.
Yeah,
There you go, yeah.
so we
Al-
usually
almost
have them always brought down to our clinic.
Yeah.
99% of the time, unless they're in HAU or ICU.
Yeah.
Yeah.
Very, very rare.
So yeah, this instance captures that rare moment when the patient
Okay.
wouldn't be coming down. So given that, does this workflow make sense for you guys?
I guess for those ones, but the ones that are coming down, like,
That's different. That was what
Okay.
we previously discussed. Yeah.
okay.
It all makes more sense when you start applying it. I
Yeah.
know it seems kind of, it's really hard to picture. And you know what, just want to acknowledge that this one's also a provider heavy workflow. So we will be teaching the providers the doctors how to do this too, like, because it's a lot about how they order it. Yeah. I just want to call out, sorry to take up more time on this one, Alex, but since we're down this
Okay.
rabbit hole, this one's, there is an order in system that is mentioned in this first box here. It's called the off-service chemotherapy RN order. And it's similar to like tasking, like do you guys use the like IV tasking, or you've heard of like how IV nurses get tasked, in that someone's got an order in system and then it goes to them and it requests like to put a pick in, or like, do you guys use any of that kind of workflow in your
No.
spaces?
Well, yeah, we
No?
do. We do.
Yeah.
Like, yeah.
Yeah, like you request them.
Yes.
Yeah, okay. You send them out in the ether and then they see
Yeah.
them on the list. So that's what this order that is available can do. If you guys wanted to have that. Otherwise, and this was really important, especially for VGH. They have a very specific team that's called the off-service chemo team. And it operates out of their medical infusion clinic. And that's because they have those BC cancer patients coming over and they're often being treated on non-oncology spaces, units. So this order is an option. If there was someone in your unit that would appreciate having a list of patients that require assessment from a chemo perspective in patients, then that's what this order would be used for. It'd be available for the provider to place, and it would task to someone who would need to monitor the list. So it might not work for you guys, but it's out there. Yeah. Better keep it a phone call.
I think a phone call.
Awesome. Sounds great. Just it's like a thing to us. Now we can tell the RDS,
Yeah.
no, you don't need that order at VGH, LGH. So that's all we needed to know. Thank you.
Thanks, Kelly. Okay. So we'll now discuss documentation regarding the NST because we didn't get to that last time. Sorry, give me a second. I have a really itchy throat today. Okay, so we're just going to talk about the nutritional screening tool. So, so current workflow, I'll break it down by each site and then the proposed workflow for each site. So currently, LGH nurses are completing, I'm sorry. Nurses are completing the NST power form and then entering a dietitian consult for patients, correct?
Yes.
Okay, so the proposed workflow will be nurses to continue that NST screen power form. I'm really sorry. Getting over a cold here, so anyway, nurses will complete the NST power form, and if the patient scores a 3 or less, the system will generate a referral for the oncology dietitian. Is that something that the site is interested in?
A 3 or more, correct? Not less.
Oh, is it? Oh, sorry, yeah, 3 or more. 3 or more.
Yes. I think it's 3 or more.
Yeah.
Yes.
It says 3 or more. Yeah.
It did. I accidentally said 3 or less, but it's 3 or more.
Yeah, that would be great.
Okay, so we'll discuss with the LGH dietitian to see what that would look like on their end and the workflow, but we'll proceed with that. Similar to Seashelt, is that a workflow that your site is interested in? Or... Oh, just on me.
If it's easier, you can type it too.
Yeah. Okay.
Yeah.
Well,
Okay.
while you're typing, I'll just quickly go over to Squamish. So currently, Squamish uses the NST for patient teaching if it's a new patient, and then a community dietitian is faxed a paper referral as they are on the Paris system. So the proposed workflow for Squamish would be nursing to complete the NST and Cerner, and the site to continue paper faxing to the community dietitian.
Awesome. Tash is on. Oh,
Hi guys,
go ahead, Tash.
can you hear me? Sorry,
Yep.
I'm in the car. Can you hear me?
That's okay. Yep, we can hear you.
Yeah, it would be, I mean, I know there's probably no workaround that, hey, that they can be, because we're just on two separate systems and acute can't take on additional resources of inpatient clinics right now, it seems. But I'm
Okay.
just wondering on our end whether I could ask whether our dietitian from the hospital was already on Cerner, whether, I mean, it would be one or two depending. It'd be quite rare that you'd have a increased workload of the nutritional screening having to be done. I'm just going to see from my end whether this is a possibility to not go to the community dietitian. But
Okay.
I think because it's an outpatient clinic, I'm going to get, it might just be have to stay the old way. But I'm going to look into seeing whether this is possible.
Okay, sounds good. And then if they were on board with that, would you want it to follow the same similar, if they score 3 or more, then it would generate a referral to those dietitians?
Yes, that would be great. Thank you.
Okay, sounds good. And I see from Hope it is a yes. Awesome. Okay, great. Okay, and this is just a little screenshot of what that looks like. So you complete the nutritional screening tool, and then this is the type of referral that would show up to the dietitian. So it shows the screening and then the encounter and MRN. Okay, so now we'll just,
Sorry, the screening tool is in ad hoc, is that right?
yep, it's part of the ad hoc.
Okay, thanks.
Oncology treatment and administration. Okay, so we're just going to discuss areas in Power Chart to review during a nursing pre-chemo chart check. So first step would be patient identifiers and their MOST status, which can be located in the banner bar. The double-signed height and weight can be located in oncology flow sheets. Any consents for treatment can be located in documentation. To review protocols or pre-chemo metrics, pre-medications, verify chemotherapy calculations, and to activate the orders. This will all be in the orders field. To document the chemotherapy biotherapy verification, that will be an iView. To document any self-administered medications or prescriptions, additionally, that will be an iView. Collect any required labs in SunQuest Collect, and documentation of medication administration in the MAW. I'll demo this out, but any questions or additional checks that your team does during a pre-chemo check?
I just had
Is
a
there
quick
any of
question.
us?
Oh, sorry.
Go ahead, Tash.
Sorry, I just wanted to ask, because I know before when chatting with Karen at Lionsgate, in terms of their cycle one, like pre-assessment, they did the nutritional scan. They also did the psychological, like the P scan. And then I think there was another one, Karen, was it the like oncology comprehensive intake? Are those the three that you do, or am I mixing that up with BC Cancer?
We don't do the psychological one at all.
You just do
the nutritional one. Yeah.
And then anything else?
No. Lee,
Like,
can you
are you
think of
still
any?
are you still getting the patient to do the personal health history, like on the like the form fast?
Yeah.
Or Not,
Yeah.
so you're still doing that and then just copying it into Cerner? You're
Yeah.
not doing the comprehensive intake in Cerner?
We're not
Okay.
yet.
So I guess my question, Alex, is like, what does BC Cancer do in terms of those? Like, I remember when Sonia Sanga was coming around kind of
Yeah.
doing the pre-research, and she had mentioned those 3 criteria for patient teaching and when you're starting somebody on cycle 1. So I just want to know if those are included in the pre-treatment stuff.
So this is specifically for chemo checking, not necessarily to their first visit. The power forms and forms that they use, I'm not very familiar with at BC Cancer, but
I can help
this.
you on that if you
Oh,
want.
go ahead, Haley. Yes, please.
Okay, so you're asking about intake documentation, Tash, which Alex, can you remind me if you have intake documentation somewhere down the line, or is it worth mentioning here? Okay.
I do have a form section, but
Okay. Yeah, so BC Cancer does use, there are power forms that are called Oncology Comprehensive Intake. And I like to say the main word in that is comprehensive. It is long. And we usually, what we do is send it and units discuss what makes sense for them to fill out in it because it's got a lot in it. And then the P-scan, some sites complete the P-scan, like the nurse clicks with the P-scan-R in system while asking the patient at the intake. Does everyone know what P-scan is when I say that? No, that's the psychological assessment. That's what they use for that. It's also quite long. But they, some sites also have just, they maintain the paper P-scan, like at VGH. So patients take the paper and they complete it and they scan it back into system. That does, anytime we do scanning of like patient assessments back into system, we always lose the ability to be able to pull that data for later. So if patients on this protocol seem to have more increased issue, whatever it might be, like it's hard to put, you can't pull that if you have paper. So just keeping that in mind. But yeah, Oncology Comprehensive Intake Power Form, P-scan, and then the NST, I think, is what they focus to. And Tasha, you have an excellent memory for getting those words bang on, by the way. But what Alex is talking, it just kind of the section that we're in here is just in regards to the oncology treatment admin. So the pre-chemo checks, basically. And then, but
Okay,
we can
sorry,
send you.
I think I'm just mixing it up with the intake and the, the
No problem.
education part, like the teaching
It's all
part.
nursing. It's all nursing documentation. It makes sense. We can send the intake info for all those forms your ways, and then you guys can decide what works or doesn't work for your teams. That's okay too. Yeah.
awesome. Thanks, Haley. I do have a section in here to discuss forms and where to find them in system. So we can go for that in a bit. So I'm just going to demo now how a pre-chemo check looks like and where you can reference each part of your check. So here I have the banner bar, and some of this might be redundant or repetitive, and just let me know if something's you already familiar with it and we don't need to review. But up here we have the code status, so that is the first place that we can check. Then for consent, we can find that in documentation. This is just an example because this is a build patient that I built. So this isn't the exact consent documentation, but you can find that and then you can make it bigger by clicking the full screen view and see the consent there. Then we can check under the oncology tab, and this is where we can locate the patient's weight. And we can check that it has been double signed here, a double signed height, and a double signed weight. Also, when we complete the chemotherapy biotherapy verification, that also pulls into the flow sheet down here, which I can show you how to do in a second. Then we can navigate to the orders. So we have our oncology order here, and we can see the different cycles here that haven't been started. Just we can see that the pre-treatment has been skipped. I just did that on my end in build, and then cycle 1. So in the power plan, we have the link to the protocol. So we can see here the, let me just pull it up on the screen. This is the BC Cancer protocol. and you can read through that during your pre-chemo check. You can also see here details of the pre-chemo metrics. So the neutrophils, so that's labs we need to check, and the platelet count, another lab we need to check. This is just a general like overview of the whole plan, and it breaks down into chemotherapy, next cycle labs, and scheduling. So here we can see there again are our pre-chemo metrics and our pre-medications. So when we want to check our chemotherapy and make sure that the dosing is correct, we can right-click this and view order information. And just pull this up over here. So this gives you a full detail and breakdown of the med, and if we click the calculator icon, that will bring us to the chemotherapy calculation. So here we can see the final dose of the patient. We can see any dose adjustments. So if the provider only wanted to dose 50%, we would see the 50%, the dose adjustment. That would also appear in red on the actual medication itself for the dose. It would say dose adjustment of 50% and in red, so you could reference there. Here we can see the height, and we can double check that it is the double-signed height used, and then the double-signed weight, and then the appropriate BSA. So that's what we can check for here. Also, some things to note here, these little icons, because this is in build, these icons are going to stay here because there's no pharmacist to verify this because it's just a test patient. So this just means that it hasn't been viewed by a pharmacist or verified by a pharmacist. And the little eyeglasses you're probably familiar with, it's just orders reviewed for a nurse. So once I'm happy and my chemotherapy is done, and also this is an option if your sites choose to do it. I just already filled it out, but this is where the nurse can check off the medication that they checked. So we just checked cyclophosphamide, and you can select as many medications as you want. So we'll say cyclophosphamide and doxorubicin. If there was any tests that I needed to verify, like if I needed to look at an X-ray or an echo, this is where I could document that. Treatment height and weight verified. So this is ensuring that I've checked the patient's height and weight and that the appropriate double-signed height and weight was used in the measurements. And then this is where I can just fill out my name. So I'm just doing a test nurse right now. So we'll just say test Alex, and I'll sign that. And similar to what I showed before, this will flow directly onto my oncology flow sheet. This is saying 2 because I have already documented today that I did this, so it's just showing that it's been documented twice.
So is this mostly for statistics? Like why, like right now we fill out our own piece of paper that says that what chemos we've given for statistics on what we're exposed to and how many hangs we've done. This isn't really for the patient, right?
This is for nursing to verify when they are going to hang the chemotherapy that it has been previously verified. This is what other sites are using. So this is completing that first pre-chemo check, and then when the nurse goes to hang the medication, they're completing their document. This is where they're referring to, yes, this dose has been double checked by a nurse.
So we're not double signing it in the MAR.
You are too. You are. So I'll show you guys the options of what different sites are using because some sites are not using this. This is just an option. Haley?
Okay. Yeah, I just thought that was for like our statistics, but if it's not, then it seems like you're doing it twice.
I'll let Haley answer.
No worries. Yeah. So there are sites, and I've worked on another center site where it's there was already built in as part of the workflow a pre-chemo check. Like prior to, like especially BC Cancer in the morning does a full pre-chemo check. They don't actually document here, but the nurse does like all the calculations, sees that the consent is there, see that the orders are there. Maybe the patient's walked in and you've confirmed that they received their B12 and all that, and like everything's good to go. So that's prior to administration, they've done a check, and that's what that would be good for. So that's why there's separation in system, but it doesn't mean that it's required. we show the options that have been built out. There are some sites that are religiously using this, like VGH. They always use both.
I couldn't give
yeah.
chemo without doing that work ever, but I've never didn't think, to me, the giving of the chemo means you've done all that.
Yeah, and that's what the argument is from other sites too. So it's fair. So especially if you guys already have 2 places, then we're giving you 2 places, but it's not mandated. You made a good point though, like for your form that you pull for like the stats of administrations, there's actually a report that's available that you can pull on actual administered meds that I was a part of as a nurse. So you won't have to track those anymore. Just so you guys know. Yeah.
Is that also happen when you sign it in the MAR, or does it have to be done here as well?
Just MAR.
Thank you.
Yeah.
Before I jump into what each sites are using, are there any questions about the pre-chemo check and the areas that I just highlighted over with you guys? Nope. Okay. Okay. So similar to what I was saying, this is where this is the workflow that each sites are doing. So similar to what Haley had mentioned at VGH, so the day before the administration, 2 nurses are completing the chemotherapy biotherapy verification section in iView. And then on the day of administration, 2 nurses are completing a bedside check and patient identification check and sign on the MA. At RHS and BC Cancer, on the day of administration, 1 nurse completes an independent double check and doesn't document this in system. And then at the time of administration, nurse 2 will complete a bedside check and patient identifiers with nurse 1, and both nurses will sign. At COFET, it's similar to VGH, but this pre-chemo or this chemotherapy biotherapy verification is happening after their pre-chemo appointment and just by 1 nurse. Then on the day of administration, 2 nurses complete a bedside check and patient identifiers. Is there a certain workflow that works best for your site? So we'll start with LGH.
Yeah, we're already doing the middle one.
Okay,
Yeah.
so you can continue with that one. How about at SGH?
Sorry, Alex, I can't see it right now because I'm driving, but we are doing the 1 nurse checks and then the 2 confirm the next day.
1 nurse checks. So the check is happening the day before?
Usually the check is happening on the Monday clinics. The nurse that's processing all the orders for the week is checking and making sure, and then it's verified by the 2nd nurse on Tuesday in the clinic.
Okay, so I'll let you maybe review when you can see this slide, because perhaps the VGH or COFET might work best for your site if you're doing it the day before, just to ensure that it's been documented. But yeah, I'll let you review. And then Seashell.
Hi.
Hi.
Hope just stepped away. I'm Susan, one of the nurses.
Hi, Susan.
So the pre-chemo appointment, you're talking about their doctor's appointment?
So they have a pre-chemo appointment with the nurse, and then the doctor. So at that pre-chemo appointment, the nurse will do the double sign height and weight measurements. Then they'll have a doctor's visit, and the doctor will then complete CPOE. And then once it's been ordered, the nurse will then sign off on this chemotherapy biotherapy verification.
Oh, on every single cycle?
They're doing this on cycle 1.
Oh, it's cycle 1. Okay.
Oh, are they doing it? No, I believe it's just Haley. Do you remember? I'm sorry, I'm trying to blank.
It's each cycle.
Each cycle. Yep. Okay.
So,
Yep.
Because we're not doing that. So the nurse is seeing each patient the day before. Like I'm just a little unclear what you mean by pre-chemo appointment. Like,
yeah, before the day of the chemotherapy administration. So if they're getting treatment on a Monday because they're not open on the weekends, then they'll have their pre-chemo appointment on the Friday, and then they'll have their doctor's visit. The doctor will enter the orders, and then they'll check the orders.
Okay, so normally here, the patients, unless they're like a day 8 or day 15, would see the doctor
prior to their cycle on a Monday. Like pretty much everyone sees the doctors on a Monday, but the nurses do not physically see the patients on the Monday. We would see them the day of their treatment.
The day of their treatment. Okay.
Yeah.
So it would probably make sense, but I'll let you and Hope review the options, but I
Yeah.
feel like similar to LGH, maybe on the day of administration, that nurse is completing the double check and then an additional nurse is doing the bedside check.
Yes, yeah, that's what we do. Yeah.
Okay, so that your workflow might be similar, but again, I'll let you and Hope review.
Okay.
Okay.
Yeah, that's definitely what we do. We would do all the pre-chemo checks the day of. Yeah.
Okay, that makes sense. Okay, great. So now we'll just discuss forms. So we had to look through your forms to determine how they'll land in future state. So some of these forms already exist within FormFast, some already exist within PowerChart, and then research and symptom management specific forms will be discussed in this a separate session. So forms within FormFast will be medical outpatient referrals for LGH, the BC Cancer patient referral form, and consents. Forms to remain out of system is the medical and cancer outpatient treatment clinic self-reporting health history, because this is a self-reporting tool that patients are using. Any questions with that? Forms within PowerChart, so community health medication and reconciliation record that is used at LGH. So components of this form can be located in the MAR, iView for documenting IV access and observations, and then also in a nursing narrative note. For the medical and cancer outpatient treatment system therapy flow sheet, so this can be documented in adult line devices in iView and then referenced in the oncology infusion flow sheet. For the immunotherapy CTCAE mapping, so this can either be in the CTCAE toxicity grading in iView, or there is an oncology comprehensive intake form. And then any consult notes can be used in the consult note.
Can you just pop back to that one?
Yeah,
You just breezed, but I just want to make sure that, so what we're looking to is to retire paper forms, except in a downtime. So we always want to keep the downtime availability, but retire these paper forms. And what we see is a pretty clear mapping in other spaces in the chart. So just want to make sure everyone's okay with retiring those current state forms from when we're in system. So I'll start with the first one, community health medication reconciliation record. Looks like it's just used at Lionsgate. Do you have a copy of the forms that pulled up, Alex?
I can quickly grab that. I should
Maybe Lee and Karen, do you know that form off the top of your heads? No?
I think that might be the one that we use to keep track of cycles. It's like a pharmacy one. I don't know what it's called.
So now Alex is racing to find her copy too. We can come back to it too. Don't rush too much. We just wanted to make sure we're clear that we're moving in the system with these.
Health medication reconciliation. I don't know what that first one is.
So it's this one right here.
That's the.
Oh, that's the MedRec.
Yeah.
Okay, so this I can see now. It's from Accelerus. It's like the PharmaNet kind of pull. And so what we're saying is that we won't need to print these copies anymore. And so we won't have to reference those. It's available in system.
And our pharmacy is doing it now. So it's out of away from nursing now.
Oh, cool. Okay, moving on to the next.
I think it's cool.
Okay, the next one is the outpatient treatment system therapy flow sheet, and I'll just pull that up here just so we have a visual.
Yeah.
So it's so it's this one. So this is similar. That can be found in the adult line devices in iView and then again on the infusion flow sheet.
Mhm.
Okay, for SSH immunotherapy monitoring, CTCAE mapping. Do you know what this one is already, Hope? Or I can find it.
I think what this was is because there's no, like for immunotherapy, often people will have symptoms that are different from if they're receiving chemotherapy. And so it was just, I think we used that toxicity mapping for immunotherapy as well. It's already in Cerner. I'm not quite sure what that's in reference to.
Sorry, that's not the one I wanted. Apologies. Okay. Yeah, so that can be found in the CTCA toxicity grading and then in the oncology comprehensive intake form.
Are you doing CRS grading? Is that what you do for your immunotherapies? Oh,
CRS? No, we use the same toxicity grading system as for.
okay.
Yeah.
You do use CTCAE. That's good.
Sure.
Okay. That's good. Knowing it's all in system, we can move forward. Just want to make sure we have what's available for you to do your grading in system.
And then, yeah, consult notes will stay in documentation in the consult note. Was there any additional forms that your sites are using that I didn't mention? No?
We have at SSH, we've got a community referral form that we send out. That's, I think, that we print up and that's on FormFast.
Oh, it's on FormFast already? Perfect. Okay.
Karen, don't you, for the new ports and that kind of thing, you do that community referral form?
Yeah.
Is
And
that
also
in?
the palliative team, we do a community referral form?
Palliative probably will be in Cerner, I'm guessing at some point. The community, yeah, I'll probably still need those forms.
Do you know if, are they in FormFast or are you unsure?
I've never looked.
Okay, if you want to send me a copy of those forms and I can take a look and see
Sure.
where they could exist in system. Okay, and then the last topic was the LGH patient symptom management, but Karen and I we were able to discuss that earlier. So great. Additionally, with the symptom management team for Squamish and Lionsgate, I may try and move the meeting to this week. Is that okay with you guys, or is this week too busy for you?
Do we have another meeting on the 30th already?
We do have the provider design session, yes.
Well, it's including the providers. So if we
Yeah.
wanted to try to find some separate time. So basically our question would be, is okay if we see if there's any availability that's shared in Outlook? Is your Outlook up to date, Karen?
Should be.
Okay, well, you just let us know if we drop it on
Yeah.
a date that is way so obnoxiously early that you
Okay.
and can't do it, and then we'll
Yeah.
move it. We're just hearing that we might have some build possibilities. We
Okay.
do like to get, like, if we can build something for you guys, we have to get the requirements in by February 13th.
Okay.
So we're just looking to get confirmation where we can sooner rather than
Okay.
later. But if it doesn't work, it doesn't work.
It's, I think, harder for me to get Lee onto the meetings. Yeah. Yeah.
Lee, is your Outlook up to date, or is there any specific times that we should avoid or aim for?
Well, I'm here all week at the clinic except for Friday, and Friday I already had scheduled in that one, but I don't have an office job, so I don't do Outlook calendars because I'm with the patients all day, every day, except for right now.
That's fair. Yeah.
It's okay.
So I guess just let us know if we need to move the time. It's an easy move, I guess.
And is that for symptom management?
Yeah.
So I know most of that stuff, but Karen, do we need, well, we can discuss this outside of
Probably
this meeting.
Sarah. Thursday might be better. Best day, like
Okay.
mid to late afternoon.
Okay, I can look in Outlook and see what works best.
Okay.
For all sites.
I
Okay.
know it's a lot of time. We just want to make sure we don't miss details because, as I said, February 13th is like the last time we can submit for build. Otherwise, we can change workflow stuff and all other things we can talk about further. But we're just making sure we're covering a build that we need to get in system for you guys.
And if it's for symptom management, could you email like Zara Tigani? I can put her name in the thing, and then she's our symptom management nurse for Thursday. So
Yeah, I can include her. Yeah, definitely.
Thanks
Okay.
all. Thanks Tash and SSH people too for joining.
Yeah, great discussion today. Before we go, any last questions?
No.
Okay.
Okay.
Thanks so much, and I'll give you 2 minutes back.
Thanks, guys.
Thank you.
Bye.
Bye.